Hello, everyone. Welcome at today's webinar about ERAS implementation. My name is Charlotte, and I'll be your host today together with my colleague Eva.
Thank you all. Thank you for taking the time this evening to join us to our Inside ERAS implementation, a team's first-hand experience. Welcome, everybody. I thought I'd give a very quick background to NCARE. NCARE is hosting this webinar today, but we have been collaborating with the ERAS Society since it's founded in 2009. So the ERAS Society develops and publishes the ERAS guidelines. And in collaboration with the Society, we support ERAS implementations worldwide. We work with the ERAS Society trainers on implementation programs, and the audit tool we have to measure compliance to the guideline is the ERAS Interactive Audit System. And EIS provides you the tool to have quality in place and have a structured audit and to measure the compliance. And it's also the pathway to ERAS qualification. So ERAS qualification is awarded to hospitals that have sustained compliance and that shows that you can follow the ERAS guidelines in the right way. And I've been working across Asia for quite some time now. So Charlotte and I, we support teams across Asia with the ERAS implementations and also with the audit platform to make sure you have the tools in place to have a good pathway in place. And I get questions all the time about what is ERAS implementation? What does it take? How long does it take? So that's the background to the seminar today, where we have invited a panel to discuss how do you implement ERAS at your hospital. So please introduce our speakers, Charlotte.
Yes, we have 4 fantastic speakers today. We have 1 ERAS trainer, and then we have 3 members from the Glen Eagles team from Malaysia, and they will share a little bit about their experience with implementing ERAS. So first up, we have Dr. Vera Lim.
Okay, so hi, I'm Vera. I'm an anesthetist from Tan Tock Seng Hospital in Singapore. And our hospital implemented ERAS 10 years ago now. And a few years after that, we've had the privilege of training teams in Asia, Asia Pacific region. And the most recent implementation was with our friends from Glen Eagles who joined us on the panel today. So I look forward to sharing some of the reflections that I have from meeting all these teams around the Asia Pacific region, as well as to addressing some of the questions that you might have. Thank you.
Thank you. And then from the Glen Eagles team, we have Dr. Shah.
Hello, I'm Dr. Sharidan. I'm one of the anesthesiologists in the department in Glen Eagles Hospital, Johor, and also the ERAS implementation lead for Glen Eagles Hospital, Johor. So as pointed out, Dr. Vera is one of our trainers for the implementation program.
Thank you. And then we have the ERAS coordinator, Anita.
Hi everyone, I'm Eniza. I'm a nurse at Clinical Hospital. I was also appointed as the ERAS coordinator when we first started the ERAS program in our hospital in March 2025. So I've been involved in the journey right from the beginning. So it has been a very interesting learning journey for me, especially seeing how the ERAS program has grown in our hospital and how teamwork can really make a difference in our patients' recovery. I'm very happy to be here today and to share some of our experience with everyone.
We are
you.
also very happy that you are here. And last but not least, we have Dr. Loy.
Hello, everyone. I'm Dr. Loy from Glen Eagles Hospital. I'm a consultant orthopedic and a joint replacement surgeon here. So I was quite lucky to be one of the members to kick off the ERAS in our hospital. And then I think ERAS has already changed a lot of our managements. And then and we have a very, very, very good result. And also we are here today to share our experience.
Thank you. And for today, we have prepared a couple of topics to discuss with the panelists. But in the meantime, you as a participant can also write your questions in the chat, and we'll try to address them at the end during the Q&A. So you're very welcome to write there. And we'll get started. And Vera, maybe for you to give us a little bit of an overview of how do the key stages of the ERAS implementation program look like, and what can a team expect if they will start with this program?
Sure. So firstly, I just like to say that the ERAS implementation is not a once-off process or once-off protocol, rollout. It's a continuous change management structured process. And we usually begin by forming a committed multidisciplinary core team. And usually the team consists of a surgeon, anesthetists, nurses, allied health leads, and usually has some leadership support. It can be purely ground-up approach, which was sort of how my hospital started. And the ERAS implementation activities are supported through actually 4 interactive workshops interspersed with practical action periods at the hospital. So I've had the privilege of being a trainer together with ERAS Society and NCARE, and working through these 4 seminar workshops with various teams. So firstly, in seminar 1, the team has to map out its current pathway. It helps everyone to understand, where we are starting from, what the baseline is, and it helps everyone to identify the gaps and what matters most locally. Every team, every local hospital can be different, and rather than assuming what we are working with, we want to really understand and identify the problem. So that's seminar 1. And then in between seminar 1 and 2, usually ownership is identified, roles are identified, and then we use the evidence-based ERAS guidelines to co-design a local pathway. So the team has to work with one another to design a pathway, and with coaches, available to guide them along, and then to test this pathway after between seminar 2 and 3, having tested on 1 patient, and then ironing out some of the kinks along the way, and finally launching it, and then measuring compliance and outcomes between seminar 3 and 4, and the results are then fed back to the team so that the pathway is refined and continually improved along the way. And I guess in a nutshell, this is what the ERAS implementation program kind of looks like.
Just quickly, Vera, how long does it normally take a team to go through from seminar 1, seminar 4?
Yeah, so it usually takes between 10 to 12 months, depending on where we are starting with, what the baseline is, and how quickly, I guess, we can iron out the differences and fill in the gaps along the way. But typically it's about, I would say, maybe 8 to 12 months.
Yeah, and the Gleneagles team, maybe you can comment on that. It took you a little bit longer. Dr. Shaw?
Yeah, I think we took about 10 to 12 months. Yeah, we kind of took it nice and easy between seminar 1 and seminar 2, but after seminar 2, we kind of ramped up our implementation, and also for the timing of the seminar 4 was also dependent on our data collection, because we need to gather a minimum number. Our Dr. Loy is our primary surgeon for the arthroplasty project. So he has lots of patients, so it was quite fast to gather the numbers. But for our colorectal and gynae, it took about 2 months later afterwards.
Thank you. And Dr. Shah, now we talked a little bit about how the seminars looked, but we're also curious to hear what motivated your hospital to start the ERAS implementation journey.
I think it was more like a bottom-up kind of a ground-up kind of implementation. The arthroplasty and colorectal we were doing some elements of it. Of course, when we started doing the implementation project, we realized that we probably only doing a small percentage rather than the 70-80% that is required to make an impact. So, but we were doing it, and we decided to actually convince the management that we probably need to do this in a proper way, which is through the ERAS implementation program. So I had to convince the management, particularly the CEO then, Dr. Kamal Amzan, who's actually now the CEO of IHH Malaysia now. So I think the 2 points that we made clear was because there's always the issue of bed numbers that, either hardware or because of the lack of nurses. And also the other point is that implementation of ERAS can reduce complications and improve outcomes. So I had to sell these two ideas to management. It took a while. There were various platforms I had to present it. And in fact, there was one IHH platform, which is the Clinical Governance Advisory Committee, because the issue is always not enough beds or inadequate beds. So I also managed to sell the idea. So it took a while. The CEO then, Dr. Kamal, was agreed to support, and he went up in terms of budget approval and things like that. And the approval in general, they had to go up to IHH Malaysia. And slowly but surely, we managed to get approval. So yeah, one thing led to another. After the approval, we were expected to perform. So, but thank God, fortunately, we managed to perform. And we are the first Malaysian hospital to be certified in not just one, but 3 surgeries.
Yeah, and that's an amazing achievement. And there are also many hospitals that want to implement ERAS, but that sort of do it on their own. So without maybe the ERAS Society or without the official program. So what specific support did you receive from the ERAS trainers, or what kind of benefit do you see in running this program together with the trainers? Ernitza, do you want to start off there?
Yeah. The support we received from our ERAS trainer, which is Dr. Vera and Dr. Kwang, was really, I think it's very valuable throughout our journey. Thank you, Dr. Vera, again. And at the beginning, they helped us understand the ERAS recommendations and, more importantly, to identify the gaps between our existing practice and the ERAS standard. From there, they guided us on how we could implement the recommendations in a way that was practical for our own hospital settings. Whenever we face challenges, especially with implementations or compliance, we had regular discussions with them. We could share what was happening on the ground, and then they will give us practical advice on what we could improve. So for me, as the ERAS coordinator, actually, their guidance was especially helpful in understanding the audit process, monitoring our compliance, and identify the areas where we could do better. And I think one of the most valuable things was that their support did not stop at helping us achieve the qualifications only. Perhaps they help us understand that ERAS is a continuous journey. It's about making the ERAS part of our daily practice, reviewing our outcomes, and continue to improve even after the qualifications. Yeah.
And Vera, I guess you see quite many teams that already started the ERAS implementation on their own. What is sort of your experience with those teams when they get started with the implementation program?
Yeah, so often I think that the teams are often very motivated, and the champions from the various disciplines are really chosen, or they choose themselves because they feel motivated in doing better for the patients, improving the patient experience and recovery. And at the same time, they communicate well with people on the ground, because as a champion and a leader, being part of the ERAS team, we often have to provide that bridge between trying to implement something, achieve a certain outcome, but at the same time communicating that, motivating the people on the ground who are delivering that care process. So I find that just meeting all this very enthusiastic, motivated people really inspires me in carrying on with an implementation and doing this work. And it's always interesting learning about the different healthcare systems, the different contexts that ERAS guidelines can be tweaked and adjusted to fit in that situation. Yeah.
And Anita, you also touched upon that the trainers helped you to identify the gaps. And I guess for that you need a baseline. So maybe Dr. Loy, since you had quite many patients, I assume the baseline was also created quite quickly for you. So what did your baseline practice look like, and where did you see sort of the biggest opportunities for improvement?
Right, thank you, Charlotte. So before ERAS, our baseline looked like most traditional hospitals. We have no standardized protocols, no proper documentations, and then the mobilization and length of stays of patients varies from different surgeons. And then, our biggest opportunity to change was to change. So we are glad that we have a world-class trainers from Tan Tock Seng Hospitals. Thank you, Miss Vera and team. And then they don't just hand us the manual, they actually coach us through the workflow. And then I think with this, then we can actually prove ourselves that we are actually able to implement all these evidence-based gold standard in Malaysia. And then hopefully we can influence the other sisters hospitals to actually adopt it.
And Vera, what does a baseline look like in the ERAS implementation program? What sort of do you need to measure or do to create that?
Okay, so we always go back to the ERAS guidelines, and they are, available for free on the ERAS Society website. But I think what matters more or as important as the guidelines is how that change process happens. Measuring the baseline is the first step. So understanding where we are with regards to the 20 plus or so recommendations that are in the guidelines is important. And that's looking at the baseline practice of most of this hospital. So that's where we see where they are and identify the high impact gaps that we can start with change in management, change improvement at that time. So it's usually 3 phases: the pre-operative part, where we gather data, for example, fasting duration. In certain protocols, they may have complex carbohydrate drink administration, for example. During the intraoperative part, there are certain compliance measures, for example, multimodal analgesia, fluid management, and of course, the post-operative part, things like early mobilization, early oral nutrition. Those are some of the baseline measures or process measures that we take into consideration, and looking at baseline as well as how we have improved along the way.
And then Vera, you're running many implementation programs across the continent. And how do you think the experience from Gleneagles relates to other implementations that you have been doing in other countries?
Yeah, I think that's a great question. And just thinking about it, I can see that there are actually many common themes across Asian hospitals. Often the champions are very enthusiastic, highly motivated to improve recovery and patient experience, but they often work in very busy operating schedules. Resources might be variable, and perhaps patient expectations can be variable as well, depending on context, on culture. Different expectations can evolve from there, depending on the age of the patient as well and the family setup. But what's encouraging is that the core approach for ERAS really translates very well. The core principles, like starting with a multidisciplinary team, understanding the baseline, and then selecting the gaps, working and adapting the workflows that is acceptable and feasible in the local context. And then using data is extremely important to measure this progress. So the experience with Gleneagles Johor is a very strong example of this. Yeah, that there is international evidence, and we used a very structured method in change management, developing a pathway that works well in their hospital, and they have done very well in achieving accreditation within the time period.
And we do see a lot of interest coming from Asia Pacific region. And Eva, you are working a lot with the market. So why do you think ERAS is booming in Asia specifically?
Yes, I see that a lot of healthcare systems are really looking for, actively looking for proven ways and quality systems to work with. There's a lot of pressure on resources, there are cost pressures, and ERAS offers a very practical solution and a framework to work with that teams, regardless of country, can work with. And ERAS provide a way to improve outcomes, work as teams with multidisciplinary teams and so forth. So having lots of interesting conversations. And we had the ERAS World Congress in Singapore earlier this year in May. It was the first time that the ERAS Society had the World Congress in Singapore and Asia, which was very exciting. So we had lots of interesting conversations. We also had an opportunity to share success and celebrate success with Mayapada in Indonesia, having qualified, the Gleneagles team on the webinar today being qualified. And we also met lots of ERAS centers across the region. So we have now across Asia, we have ERAS centers in Korea, we have it in Taiwan, we have in the Philippines with training centers. Vera mentioned like Tan Tock Seng Hospital has been a training center for many years. We also have Medical City in the Philippines that is a training center. And we actually expanding training centers across the region as well, which is really good. So we can provide more implementation programs for those interested. So we have, I know we have some participants from Australia today. So we worked with for example, Peter Mac for many years. They're a center of excellence down in Australia. So we're seeing now that we have interest across the countries. Indonesia and was first with Mayapada, and Malaysia was first with the Gleneagles team. We have just started an implementation program in Thailand recently, and we are about to start one in Vietnam. So I'm very excited. And Vera, you are a global traveler, but you also see a lot of people reach out to you and visit Tan Tock Seng Hospital to learn, because a lot of hospitals that I come across are in touch with you. So maybe you can also touch base where you see the interest has increased recently in ERAS and implementing ERAS in a structured way.
Yeah, so we've had quite a few requests to visit the center, because I guess it's one thing reading about it, but another thing actually observing it for yourself, I guess. Then you can think about whether something like that might work for your hospital, or there are certain things that you might want to tweak. We do share about some of our not so successful pathways or experiences as well. And I think that it's important to learn from pitfalls as well from other places. So we've had quite a few hospitals visit us over the years, from Malaysia, from Hong Kong, Taiwan, Vietnam, Indonesia. And it's always useful for us as well to learn from these hospitals that come and visit us, that we always learn something that we can adopt and tweak in our setting as well. So I think in the recent couple of years, a lot of interest, I think, from Indonesia, Malaysia, and actually Taiwan hospitals are also getting more interested as well. Yeah. So, and I think we've also had visitors from Korea and Japan as well. So really quite a lot of Asian countries and friends have come and visit us.
And we have many people on the call today, and many are from different hospitals, and maybe they are interested in starting the ERAS implementation, but they're not really sure how to get the whole team on board. So, Dr. Shah, how did you gain the buy-in from other surgeons, anesthesiologists, nurses, and also, yeah, your hospital leadership?
I think in the case of Gleneagles Johor, it was more like formal as well as informal meetings that we talk about implementing ERAS. But I think it was more of the informal chat that actually solidified the effort. The corridor chat, the chat over coffee, and I think that's what actually made the buy-in possible. Surgeons, they are examples like Dr. Loy and Dr. Sandeep, our colorectal surgeons, are already doing some elements of the ERAS protocol, so it wasn't too difficult. The gynecologists needed a bit of persuasion. As far as my department is concerned, I think when the idea of implementing ERAS came about, it wasn't too difficult because I think most of the intraoperative elements were already practiced, but it's a matter of getting them to document. I think that's where the issue is, because a lot of hospitals will say that they are doing ERAS, but data may or may not support the idea. So when we started documenting, it was easy to convince them. We haven't to convince my colleagues to actually say let's do more of this or more of that, because of the fact that when we saw the data being collected, we need to kind of improve on the some elements of the implementation. Nurses, I believe this wasn't too difficult. Anisa will probably talk more on this, but I would just like to add the importance of having an ERAS coordinator who was going to probably bring all of these elements, surgeons, anesthetists, dietetics, physio, nursing, and everything together. It can be someone non-nursing, but majority of the time I feel that nurses will probably be the best person to actually coordinate. Hospital leadership, as long as they can justify Gleneagles still being a private hospital, as long as they can justify in terms of ROI, and I think ROI for them would probably be certification. And we have shown some data from our implementation certification that we have reduced length of stay significantly, particularly for colorectal. I think this is where IHH Malaysia is already looking into implementing it throughout the group. So we have had some sessions to actually inform and actually educate the other sister hospitals in IHH Malaysia.
Thank you. And you already talked a little bit about the important role of the nurse or the ERAS coordinator. Anita, would you like to share a little bit of your experience?
From my experience, I think the nurses really plays a important role in ERAS, because the nurses are the ones who really bring the ERAS pathway to life at the bedside. We can have a very good protocol on paper, but at the end of the day, someone has to translate the protocol into what actually happens to the patients. So the nurse's role starts even before the surgery. We educate the patients about what to expect, like things like fasting, nutrition, early mobilizations, and what their recovery will look like after surgery. I think this is very important, because when patients know what to expect, they are more prepared to participate in their own recovery. Then after the surgery, and this is where the nurses really play a big role. For example, that Our plan may be for the patient to start walking within a few hours after surgery. But when we approach the patients, they may say, I think probably of the patient will say that I'm in pain, I feel dizzy, or sometimes simply say that I'm scared to move. So instead of just documenting that the patients did not mobilize, we need to ask why. Why? Is it pain? Is it nausea? Or is it patients dizzy? Or are they simply afraid to move? So once the nurses identify the barriers, they can address it and involve the appropriate team member, whether it's the doctor, physiotherapist, dietitians, or another member of the multidisciplinary team. And then we help the patients move forward with their recovery. And it's the same with eating and drinking, pain management, removal of tubes, catheter, and also prepare the patients for discharge. So as a ERAS coordinator, I also see nurses as important connections between all these different disciplines. We are constantly observing the patient's progress and communicating with the team. So for me, the nurses are not just following the ERAS checklist. So they are identify what's stopping the patients from progress. They coordinate the care, and most importantly, they help turn the ERAS plan into the patient's actual recovery. So from the buy-in, it did not happen overnight. At the beginning, one of the biggest challenge for the nurses was ERAS was something new. Some nurses may see it as another protocol, another checklist, or additional work on top of what they are already doing. So for us, like education was very important. Um, we do not want to just tell the nurses that this is ERAS and you have to follow it. So we want them to understand that why we are doing it and how this ERAS element actually benefits for the patients. So for example, instead of simply saying the patient needs to mobilize early, we explain why early mobilization is important and how it contributes to the patient's recovery. So we also use like patients as example. When the nurses start seeing patients getting out bed earlier, eating earlier, and recovering well, so ERAS had become something they could actually see working, not just something like written in the protocol.
Oh, thank you for that answer, Anita. And I think everyone on the call can only echo how important the ERAS nurse and coordinator is. And Dr. Lloyd, besides a surgeon, anesthesiologist, and a nurse, do you have some other members in your ERAS team?
Yes, we have surgeons, anesthesiologists, nurses, yes. And then shouldn't forget the physiotherapists and also pharmacists. And of course, the patient, they themselves should be aware that they are actually actively play active role in the ERAS program. So they will be well informed before even the surgery itself. So from the clinics, yes, we already prime the patient that we expect them to move early, and then we'll give them adequate analgesia, and then yes, we'll reassure them that we will hold them in our hands, hand in hand. We will make sure that they have a lot of support from our side, and then we want to have make sure that they mobilize early and then have a faster, safer recovery. So actually, it involves many teams. Yes, multidisciplinary teams, but I think the important thing is how to get every one of us to communicate. And then initially, yes, we may have hiccups here and there, but after some time, it's just like a more of a norm. And then patients are well convinced that they can actually do this by day one, and then what they can expect on day two. I think things will flow much easier towards the end. And then, of course, Anisa and team plays a very good role, very important role. We may initiate the surgery, but the nurses actually bring the patients to the finishing line. And then, yes, everyone celebrates the success together. Yeah.
Yeah, it's truly a multidisciplinary team effort. Vera, how important is data in driving change, and how do you keep the teams engaged with measurement and improvement?
Yeah, that's so data is actually the backbone of the entire, change management process. So we need to understand the baseline, and that's the where we're starting from to identify the gaps. And then process data is important so that we can understand if the pathway is being delivered. So for example, Anisa, raised a very practical translation of that, which is if the nurses see that, oh, the patient is not wanting to get out of bed, and the question is why, and then you can tweak the pathway to address that. So whether it's pain or giddiness or just fear because of, I guess, expectations are not aligned. So education perhaps needs to be delivered in a different manner, for example. And then finally, outcome data is to understand whether the pathway and the change that you have made is making a meaningful difference for the patients and the overall system. So in how to keep the teams engaged, on the picture on the left side where you can see some bar charts, that's actually put up in the wards, ERAS wards of compliance data for the year, so that the people on the ground can see what they are doing, whether it's translating to achieving that process measurement or the outcome measure. But perhaps, having a big report for 1 year is not so useful, but we need data that is actionable. So short, quick reports, we make the feedback timely and visible. Of course, and when there's good data, we need to celebrate the wins as well to keep, teams engaged and motivated, and to let everybody know that what they are doing is actually making a difference. And when the team is engaged, then they would often come up with solutions as well. So it's important that the data is used in a practical, non-punitive manner to for regular feedback. So on the picture on the right, we see our coordinators being educated about the audit system, how to use it, and that data really makes a difference in ERAS care.
Yeah, I will just make a quick comment because I get lots of questions that mentioned in the beginning. ERAS NCare developed the ERAS interactive audit system, and it is the audit platform that is used, and it is the tool that is validated by the ERAS Society, and it's also the tools the trainers use to measure the performance during the implementation program and finally make the assessment if the team has qualified or not. So to achieve ERAS certification, the society trainers use the audit platform in order to measure pre-ERAS and ERAS and decide if the team has qualified, and which is the case with the Gleneagles team. So they met the requirements from the ERAS Society for qualification, and thus is now qualified. And as mentioned by the team, that work continues. So continuous audit helps the team focus on what Vera said, what continuous improvement.
Then maybe as a last question from us to the speakers, a quick round the table, maybe one sentence from each of you. What piece of advice do you have for teams yet to start with the implementation? Anita, may I start with you?
So I think for me that this program ERAS is very, very good to improve patients' recovery. I think it's it make us learn that it is very important to prepare patients before the surgery, so that patients know what the expectations, that what will happen before, during, and after. Because from my experience that the patients that didn't prepare earlier, when they come to the hospital for the surgery, when we ask them to mobilize, they will be mostly scared but most of the time that all the patients that we prepared early, they have some kind of motivations to do it, and it end up with most of them is very good recovery.
Thank you. Dr. Shah, what is your piece of advice?
My piece is, I think, you need to give different members of the team the why. The hospital management may look at a different reason to implement this. The doctors may look at different reasons. But if we address the big why, then I think implementation or the buy-in will be probably a lot easier. That's my piece of advice. Thank you.
Thanks. Dr. Loy?
So on my side, yes, I think we have to trust the ERAS system, and then let the data guide your decision, because initially we do not know where to start. That's why we start collecting data, and then we know where we are lack, and then from there we'll try to improve. And then like for example, previously I do all the total knee replacement with a drain inside too, and then nowadays I don't put drain anymore. So we are always trying to push the limits, and then we try to match whatever evidence base has given us. So the next advice is when to start. So I think the best time to start was actually last year, and then the second best time was actually today. So don't try to rush to finish it up, and then because you can't change the system, you can do all the overhaul everything in a day, but take a step at a time, and then yes, you will slowly reach to the desired outcome.
Thank you. And then ending the round with Vera.
Okay, so I guess for me, my piece of advice is, like Dr. Shah says, to have more coffee with like-minded people. You really need to find a committed team with a shared motivation, and have that constant, regular communication, education, because that is what's required for sustaining, implementing that practice, workflow redesign, and measurement, and working through the gaps. So have more coffee with your friends and find a group of people that are equally motivated as you.
Well, thank you. We are running a little bit out of time here, so we're going to skip the Q&A, but we're going to ask you if you have any questions to just send them by email to us afterwards, and we will share our email addresses, and then we'll make sure to forward that to the speakers. So that brings us to the end of this webinar. So thank you to our speakers. I'm sure it was very helpful and very, very interesting for everyone in the audience to learn from your experience. We'll also be sharing the recording of this, so you can watch it back, or you can share it with any of your colleagues, or if you're trying to get a buy-in from your other hospital members, you can share this as well.
Yes, thank you. And as mentioned at the start of this webinar, we are here to support you. ERAS Society and NCARE, we support implementations globally. I want to say thank you to the audience for taking your time. I know everyone has a very busy schedule. I will mention very briefly that I am normally located in Sydney, Australia, so in a similar time zone, but today I am in Stockholm, Sweden, together with my co-host here, Charlotte. So having a few meetings, and tomorrow I'm having a meeting with the founder of the ERAS Society, Professor Olle Ljungqvist. So if you have any specific questions that the team here today did not address, or you want to maybe address with the ERAS Society, please reach out to me. We'll post the email address here at the end. You can possibly take a screenshot of this. So my email is eva.renander@ncare.net, and I will connect you with the proper people, and we can continue the dialogue and the discussion and have lots of coffees on what it means to implement ERAS and achieve success, and most of all, enhance the recovery for patients worldwide, one patient at a time. So it's so great to see that the global community of ERAS is expanding, and we certainly have lots of work ahead of us to get this message across. So thanks to everyone for sharing, being part of the webinar today, for continuing to share your experience, your stories, and for bringing new members along the team. Looking forward to our continued conversations offline. Thank you, everyone.
Thank you so much, and hope to see you at the next webinar.